Okay, so this evening we have Dr. Buono with us. One second, just Dr. Lee Buono is Director of Neurosurgery and Neurointervention for Capitol Health, as well as the Director of the Center for Spinal Disorders and Spinal Oncology at the Capitol Institute for Neurosciences. A board-certified neurosurgeon specializing in minimally invasive spine surgery, Dr. Buono treats patients dealing with the full spectrum of spine conditions, including degenerative diseases, vascular disorders, spinal injury, spinal tumors, and infections of the spine. He joined the Capitol Institute for Neurosciences, part of Capitol Health, from Texarkana, Texas, where he was in private practice and was on staff at Christus St. Michael Hospital and Christus St. Michael Rehabilitation, Wadley Regional Medical Center, and Health South Rehabilitation Center. Dr. Buono is originally from New Jersey and received his bachelor's degree in neurobiology from Rutgers University. He then went on to receive his medical degree at Jefferson Medical College and completed his neurosurgical residency at Thomas Jefferson University Hospital. A fellow of the American College of Surgeons, he has authored numerous book chapters and publications focusing on congenital intraspinal anomalies, technical considerations of stereostatic frames, and cardiomyopathy. Dr. Buono performs traditional and newer minimally invasive approaches to spine surgery. This includes performing axial lumbar interbody fusion and direct lateral interbody fusion, minimally invasive alternatives to traditional fusion procedures. His use of minimally invasive approaches means his patients spend less time in the operating room and recover more quickly. Dr. Buono is a member of the American Academy of Neurosurgeons, the Pennsylvania Neurosurgical Society, the American Academy of the American Academy for Neurology, and the Society for Neuroscience. Thank you for joining us this evening.
Thanks, guys. That's great. So this talk is about, it covers all the problems with spine surgery, all the stuff that you've heard about, all the issues. So, you know, when you talk to your friends, they say never have spine surgery. Well, there's a reason for that. It's not folklore. It's actually true. So go to the next slide. So spine surgery has been molded through the years and changed because of many different factors. There's influences on reimbursement to the physician. There's influence based on the research that's done for spine surgery, how it's tainted by the vendors, the people who make the spinal implants. And like everything in life, ladies and gentlemen, it's influenced by money. And where there's money, there's bad. So when you see a spine surgeon, I'm here to tell you what's the ins and outs and how to figure out what's going on and what's the appropriate treatment. So we're going to kind of step back a little bit and talk about some details of how spine surgery got jilted through the years, and then go into how you should approach your own problem if you have an issue or your family has an issue with your spine. Next slide, please. Okay, so we kind of touched on this. We spend a lot of money on spine surgery. The training for spine surgery is long and hard, and so some people get trained well, some people don't get trained well. And if you're leaving a neurosurgery or orthopedic residency and you want to do spine surgery, usually it means you have to do extra training. A lot of people don't want to do that extra training, so they maybe won't, and they'll just go into spine surgery and start to do it. And guess what? You won't know, because every doctor has one good patient. So every doctor will have a decent reputation based on who you ask. So you have to be careful. The public is misinformed about what goes on during spine surgery. There's a lot of money changing hands, and there are some bad patients which influence the outcomes of spine surgery. Next slide, please. So here's a noisy slide. I don't like this presentation at all. I'd rather talk to you up front and in person, but we spend a lot of money in spine surgery, okay? It's going up and up as the years go on. Next slide, please. So for instance, if you Google spine surgery, you get, over 1 million hits. Back pain, same thing, right? The fact of the matter is, if you look at the statistics of basic spine problems, basically everyone, as long as they live a normal life, a full life, they're going to have a problem with their spine, whether it's their neck or their low back. Everyone's going to have it. What people don't tell you is that 86% of all spine problems go away without any treatment inside of 3 months. Hence, non-surgical treatment. But the patient has to realize what type of non-surgical treatment is necessary and what is not. Now, if you look at the bigger picture, the more scary picture of what you are all thinking about, it's around a little over 78% of patients who undergo treatment for spine problems, whether that's surgery or non-surgical treatment, had a treatment that's not necessary. Think about that for just a second, okay? So the vast majority of patients who have a spine problem, they go see a doctor, they have some type of treatment, whether it's surgery, epidural steroid injections, physical therapy, whatever it is, it's not necessary. It's either done for money or by a doctor who's misinformed or is on the take. Next slide, please. That's a scary stat. So the research in spine surgery, if you look at it, our data is terrible because no one wants to offend anybody. And Lord forbid we come out with a paper that said spinal fusions aren't very good, then people who do spinal fusions aren't going to be doing spinal fusions anymore. And guess what? A lumbar decompression, that just means taking the pressure off the nerves. That's not a fusion surgery. That gets paid, let's say, around $300. A spinal fusion gets paid $5,000. So I wonder why the vast majority of patients that come to see me for a second opinion are told by another spine surgeon that they need a fusion when they don't. Now, my job is then to tell them the truth, teach them how to read their own MRIs, their own films, take a little time, teach them the common sense, show them some data, and then say, guess what? You don't need that spinal fusion. The funny thing is, when I say that to them, you don't need a fusion. Now, I do fusions on people, but if I say to them, you don't need a fusion, they have a hard time believing me. So next slide, please. So in training, the training hours are less. It used to be when I was in training that we would train nonstop. We got 4 days off a year and it was 24/7, spinal surgery and trauma surgery. So now they cut the work hours to 80 hours a week so people get to leave and the residents don't fall asleep, blah, blah, blah. So the training sometimes isn't that great. You got to be careful where people train. Next slide, please. This is what we touched on before. Most people don't need spinal fusion. Spinal fusion, for those of you who don't know, it means that I'm putting screws and rods in your back to fuse one of the bones in the spine to the other. So I'm joining two bones together. That's fusion, okay? So lumbar decompression just means the tube where the nerves go through is narrowed. So I just opened up the tube somehow, some way, and take the pressure off the nerve so your pain goes away. Next slide, please. So this touches on some of the surgeries that we do. Lumbar artificial discs, a lot of people love doing those. That is a great procedure in certain age groups. But artificial discs wear out just like artificial hips. You know that those of you who have had bad hips and you went to see the orthopedic surgeon when you were younger, he was really reluctant to do a hip replacement because you were so young and you're going to wear it out in your time frame of you being alive. Cervical artificial discs, pretty good. Some are off the market now and most of the insurance companies don't pay for them, but it's a much better alternative than a fusion. And then we talk about extreme lateral approaches, dynamic stabilization. So the way it works now is the doctors are getting paid less for each surgery. And the insurance companies are trying to restrict the number of fusions you can do. So when a doctor gets paid less, well, he says, I still got to pay for my Maserati. I got to make more, so he'll do more fusions. So you've got to be careful. Next slide, please. This is kind of it's kind of a noisy slide. Just go to the next one. We touched on this already. I'm interested to get to the MRI where I can go through with you. There's a crazy patient. So we get patients like this. Some patients can't be helped. So we grade patients A, B, and C. Okay, so if a patient comes to see me, I don't care who you are. In my brain, I'm grading you A, B, or C. A patient who's a grade A patient. The analogy would be a young, healthy person, let's say 10 years old, with a splinter in their toe. You take the splinter out of their toe, and there's nothing wrong with them. They're completely happy. They're 100% happy with the little procedure you did, and they have no problems. A type B patient has a splinter in their toe, and they have arthritis in their knees. So you take the splinter out of their toe, and after surgery, a little splinter removal surgery, we'll call it, they're still going to complain of problems walking because they got arthritis in their knees. A C patient either has some mental issues or also has multiple medical comorbidities. So they're morbidly obese, so they have heart disease, and they're still not going to be able to walk because they don't have the lung capacity, or they have COPD, or they're a heavy smoker. So there are some bad patients out there, but it's the doctor's job to discuss with the patient the single most important thing. What is your outcome going to be? What should you expect? If you're diabetic with peripheral neuropathy and you can't feel your feet, and you have a disc herniation, well, I can get rid of your back pain, your leg pain, but you're still not going to be able to feel your feet when you wake up because you have diabetic neuropathy. So patients need to know these things. And if a patient comes in and they've been on opiates for 10 years and they're ex-cocaine addicts, they're probably not going to do as well as Mr. Smith, who has a regular job and doesn't take opiates. Next slide, please. So there's no bad patients, only bad doctors. That is definitely true, because if I have a patient who has medical comorbidities or other issues, it's my job to explain to the patient why either they're a bad patient for surgery or their outcome is not going to be what they think. So realistic outcomes. We discussed, one of the things that you guys don't realize maybe is if you're on opiates before surgery, gives us problems. So after surgery, when you take opiates, that's, Percocet, things like that, it releases histamine. Now histamine, you guys know what antihistamines are. Histamine causes inflammation in your joints and inflammation in your nerves. So it actually acts as a neurotransmitter. So if someone's on opiates for a long time and they have surgery, they're going to have a hard time recovering because they're addicted to opiates, physiologically addicted. So it's one to think you have to think about that not only before surgery, but after surgery. And if you're on opiates, get off of them. Please get off of them. There's other treatments aside from opiates. Next slide, please. There's that guy again, okay? So he's still on the opiates. Next slide, please. So what you should do, the first thing is when you go see the spine doctor, whoever it is, you should have certain expectations. Number one, you should expect that the spine doctor explains to you what your problem is. Not, you have a disc herniation, you need surgery, or you have a bone spur in your neck, you need surgery. That is not an explanation. They need to show you your MRI or your CT scan or wherever it may be, and teach you how to read that scan, show you what the bone spur looks like, where it is, how it is, what it does, and why. So before you have surgery, do not trust anyone who doesn't explain it to you. Because if they're not explaining to you why, then they may be pulling the wool over your eyes. And if you don't understand everything of why you're having that surgery, the outcome and how it's performed before you have the surgery, you're doing a disservice to yourself. So if you go to a spine doctor and you still don't understand the whole thing, and they really didn't take their time to try to explain it, go get a second opinion. So reluctance to operate is a good thing, you know, believe it or not, even though I'm a spine surgeon, I'm a neurosurgeon, my ultimate goal is to fix the patient without doing surgery. Now, how do we do that? There's a number of ways we can do that. But most patients, like I said, 86% don't need surgery. Most patients. Here's an example. Let's go to the next slide. Next slide. This just talks about, this was a lecture I was giving about state of the art from some nurses. There's a difference also in timing. If you're having a standard old spine surgery, let's say your spine surgeon wants to do an anterior cervical discectomy and fusion. That surgery can take some surgeons 4 hours. It can take them 2 hours. It takes us about 20 to 30 minutes. And it's done as an outpatient. We could do a lumbar fusion in about a half an hour. But some people take a long time. It doesn't mean it's bad, but they're probably doing open surgery. Open surgery is a bigger procedure, harder outcomes. It's a much longer recovery, and it's tougher for the patient because it's a lot more surgery. So keep in mind, you want to ask, is this minimally invasive surgery? Is this, you know, state of the art? This is the cutting edge kind of stuff. And if you're not sure, get a second opinion or get a third opinion. Next slide. Next slide. We don't need to know about thoracic spine. You're never going to have a problem in your thoracic spine. So this talks about discectomies and fusions. Again, this is not really jilted towards you. You want to go to the MRI. Go to the next slide. So we're going to talk about some great stuff. Okay, so this is kind of what I expect my patients to expect. The surgery should be done as an outpatient. Sometimes your insurance companies, no matter what the surgery is, sometimes your insurance companies will say you have to stay overnight. And that's okay. It's usually Medicare. But otherwise, the vast majority of surgeries I do are done as an outpatient. And sometimes patients will wake up and they're a little sore and they want to stay the night. That's okay. But they shouldn't be staying days in the hospital. It's always just at most 1 night stay. That's it. All spinal surgery should be understood by the patient. We discussed this. The operative times, if they're talking about operative times to you, and they're saying this surgery is going to take 8 hours, please get a second opinion. 8 hours, there's nothing that I do that takes 8 hours. I could mow my lawn and my neighbor's lawn. It doesn't take 8 hours. So that's a long time. If you think about the risk of surgery, the major risk of any surgery, it's called TOT, or time on target. So the longer you're under anesthesia and having surgery, the higher the risk of infection and complications from anesthesia. So an 8-hour surgery is a long surgery. We talked about realistic outcomes, and that when you have spine surgery, it shouldn't be relief for a couple of days. You should have relief for a long time, or else why are you having the surgery? Let's go to the next slide because this is boring. I can't wait to get to the MRI because you're going to love that.
I'm working on it. It's like frozen on me. 1 second.
It's okay.
There we go. Keep going.
Keep going, yeah. So this is an example of minimally invasive surgery. So if someone needed a lumbar fusion, okay, most people, and in the olden days, so that's most spine surgeons, would do open surgery. That's an incision about, let me see where the camera is, about that big, about the, let's see, about that long. That's pretty long incision, okay? The surgery is usually around 6 hours. They put big rods and screws in you. It's a big incision, hurts real bad. And they have to cut through, can you guys see my arrow or not? Well, they have to cut through the muscles in your back and strip the muscles off the bone. That hurts. That's painful. Or you can go through your belly, which the intestines are there. I don't want to do that. That's kind of scary, right? Or you can do what's called a direct lateral antibody fusion, D-lift. D-lift goes through your side, also called an X-lift. You go through your side where there's no nerves, the nerves are over here, there's no muscles in the back, and there's no organs, all the organs in the front. So you go through the side with a little tiny incision like that, do the surgery, and voila, you go home. There's no big incision, there's no ooh-ooh, there's no pain, and no risk of problems with damaging your nerves. So this is just an example of new techniques, relatively new techniques that we use to get to the spine in certain areas and to make the surgery much more efficient, safe, and effective. Next slide, please. Axial lift surgery has really strict indications, but we can actually do a lumbar fusion at L5-S1 by going kind of rear, just around your butt. So we go up here, avoiding all the organs. That's the axis. It's all just fat back here, real face. It's real safe. So there's no nerves to bother. There's no ooies. There's no dangerous areas. And we can put a little rod through there, take out the disc, minimally invasive through a little tiny microscopic tube, and then do a fusion. It's pretty neat. Next slide, please. That's an example of an axial lift with transfacet screws. So we're doing a fusion, not going through your belly, because that hurts. I go through your belly. I got to cut your rectus abdominis muscle, your abs. I got to open that up. I got to move your organs aside, right? You don't want to do that. That hurts. I don't care who you are. Any women out there who've had babies or hysterectomies or C-sections, you know what I'm talking about. So here's an example of a real cool surgery that we can do. Next slide, please. This is an example of minimally invasive fusion from the back. So it's not some big incision that goes along the whole length of your back that's like 8 inches long. It's two little tiny incisions on the sides of the paraspinous muscles. So there's no big stitches, just a couple little tiny scars when you're done, and it's happy-go-lucky and only done in about 20 minutes. Next slide, please. So other things that we use, this is kind of boring for you, but we use special types of grafts. We use bone morphogenic protein. We use your own stem cells. How do we get the stem cells? Well, you're asleep. You put a little needle in your iliac bone when you're sleeping. We take out the bone marrow. We harvest the stem cells. We use that for a fusion. It's better than using some dead guy's bone, right? And it doesn't hurt. There's no chunks of bone I'm cutting out or anything like that. And the fusion rates are amazing. Next slide, please. So this is where people try to manipulate things. You wouldn't know it, but your surgeon may be using certain types of implants that get reimbursed a little bit more, certain types of metals and grafts. You wouldn't know it, but it's something to look into, and that's why second opinions are important. Next slide, please. Here we go. This is the important part. Okay, so this is what I do with my patients. I'll pretend all of you are just listening to me, and you're in my office right now. So, and you can't see my arrow, right? Is that correct? My arrow moving around? No?
Yes, I can see it.
You can see it? Okay.
No, they're seeing my arrow, not yours.
Oh,
Oh, that's
right.
your arrow? I see an
That's your
arrow. It didn't
All
have
right,
a name on it.
This is a side view of the spine, okay? So point to the right-hand side of the slide.
Right.
The white look, yeah, so all that is fat. So that's the back, okay? And down there's your butt. And in the front, which is the left-hand side of the slide, is your belly. And the little lines you see there, point to one of the lines.
This one?
No, the lines that are the big, thick lines.
Oh.
Yeah, that's a disc. That is a disc, okay? And then the big white stripe right in the middle, that's where all the nerves are. The nerves go through that big tube. So without knowing anything, now, and you're the moderator, right? Point to the disc herniation.
Right.
Show the patients where the disc herniation is.
This one?
Show where it sticks out in the tube where the nerves are. Yeah, there you go. That's a disc herniation. It's pinching on the nerves. Are any other discs herniated?
Maybe the one right after it.
A tiny bit, but not really. It's really basically L4-5 disc is huge, right?
Mm-hmm.
So now you'll go to a doctor and they'll show you this disc and say, okay, well, your insurance company, in a lot of cases, wants you to have physical therapy. Well, let's think for a second, ladies and gentlemen. You're all smart. What is a disc? Well, a disc is the same thing as a jelly donut. So the inside of the disc is called the nucleus pulposus, big fancy word. And the outside is the annulus fibrosus. It's tough material, like gene material. So if the outside tears a little bit like a jelly donut, then the jelly squeezes out. So if someone said to you, see that jelly donut over there that's kind of leaking out? I want you to push on it. You would say, you're nuts, because more jelly is going to come out, right? Yeah. So why in hell would someone say to you, hey, you have a disc herniation, go do physical therapy and lift weights. That's no different than someone saying, you got a broken arm, don't use a cast, go lift weights. You would say you're nuts. Same principle. So with a disc herniation, you don't do physical therapy. No, you relax. And disc herniations are usually categorized. The bigger the disc, if it's huge like this, it's probably not going to go away, less likely, right? If the disc is light in color, that means it's soft, more likely to go away. If it's very dark or black, it's hard cartilage, not a lot of water, probably not going to go away. So usually you can tell or predict most of the time whether these discs are going to go away. A disc herniation like this, we know that 86% of disc herniations go away without any treatment inside of 3 months. So if this patient came to me, disc herniation started a week ago, I'd say, okay, well, I can give you a little steroid pack if you want, if you're not diabetic. We could do an epidural steroid injection. For you guys in the room, if I do an epidural steroid injection, will that get rid of the disc? No, it will not. It doesn't dissolve the disc. It gives you anti-inflammatory medication so the nerve isn't so angry. The nerve's getting punched like this. So you give it anti-inflammatory medicine, the nerve feels better and allows you to feel better as that disc kind of retracts back into the annulus. So there's a disc herniation. Now, if you have a deficit, let's say you come in, you have a disc herniation that started a couple days ago, and your leg's paralyzed, well, you need surgery. But the longer it's paralyzed, the less likely it's going to come back. So you need surgery if you have a big deficit. But otherwise, the vast majority of people with disc herniation, which is the most common thing, they don't need surgery. You give them a little anti-inflammatory stuff, tell them to take it easy, give them a note for work, don't lift anything heavy, which is common sense. It's a jelly donut. Don't lift anything heavy, take it easy, and 9 times out of 10 it goes away. If it doesn't, then you could do a little surgery. If you do a little surgery, what's the surgery? Well, you're not taking out the whole disc, you're just taking out the part that's squeezed out, the part of the jelly that's on the ground where the ants are eating it. And that decompresses the nerve and then you feel better. What's the risk of that surgery? Well, you can still have another disc herniation because there's still disc inside there. We're not taking out the whole disc. The risk of recurrent disc herniation nationwide is about 4 to 6%. So whether you get surgery or not, once you get a disc herniation, you could still get another one. So it just means don't be a fool. Don't help your cousin Eddie move furniture. Let it heal. Please, hopefully you guys are writing down a lot of questions on this one because this is the classic mistake that patients make. The doctor doesn't show them the films. They say you have a disc herniation, you need surgery. They don't describe why the disc herniation is there, which side it's on, how it's pushing on the nerve, why you need surgery, why you don't need surgery, how big the disc herniation is, what it looks like, blah, blah, blah. So a picture is literally worth 1,000 words. Next slide, please. So that patient, that exact patient with that MRI and that disc herniation, that's what surgery they had. They had a fusion. Did they need a fusion? No. No. They did not need a fusion. Fusions for instability, where the bones are moving like this, or a fracture, things like that, or even if you had multiple recurrent disc herniations, but that patient did not need a fusion. So why did that patient get a fusion? Well, the doctor said that they needed a fusion. They had good insurance, and hey, he needed a car payment. And that patient had no idea. No idea. That is the wrong surgery. That is the wrong surgery. It's like saying to your doctor, I have a headache. And he says, well, I'm going to cut open your head. I'm going to cut it open, scram around there, and I'm going to look and see if there's anything in there. No, no, no. Take some aspirin. That's the treatment for a headache. Next slide, please. So here's another example. Now you can read your own film. So you here can look at this film. It's an MRI of the neck, cervical spine. So that gray thing in the middle surrounded by white is the spinal cord, okay? And you can see the discs, those are the little lines. See the little lines? Now you got, how many discs sticking out there? 1, 2, 3. 3 discs sticking out, okay? That's called spondylosis. There's little bone spurs. Now, if you look at this picture and the spinal cord itself, behind the spinal cord, there's water. That's the white stuff. So this patient has some bone spurs in their neck. They got probably some neck pain. but there's no compression of the spinal cord because there's water behind it. So this patient was sent to me. They said, look, I got this problem in my neck, got some neck pain. We started them on some Celebrex, some arthritis medicine, gave them some physical therapy for their neck because it's spondylosis, bone spurs. They felt better. Years down the road, they went and moved and went and got a second opinion by somebody else, and show them the next slide. That's what they did. So the first surgery is on your left. That surgery failed from what's called a non-union because they didn't fuse and didn't need the surgery. Then they had another surgery after that with a fusion through the back and through the front. So now that patient has no motion in their neck. They have neck pain. They never needed that surgery and now had an additional surgery, which is a huge surgery, completely unnecessary. Now, what's the benefit of that? Well, nothing. Well, the doctor probably bought a new shore house, maybe a new car, but lied to the patient. Yeah, I mean, that's one way to fix your neck. I could do a fusion on everybody that's out there, but they don't need it. Some people do need fusions. This one didn't. Next slide, please. So here's a quiz for you out there, and then talk out loud amongst yourselves. I'm not going to be able to hear because they're on mute or something. So this is a lumbar spine MRI, okay? And you already know the anatomy. The back is where the little fat is, that's the butt, and the front is on your left, okay? The tube where all the nerves go through is that white tube right in the middle. You can see that's the white tube, right? And then you could show them a normal disc, point to a normal disc. See that? She already knows this, so she's not been trained, okay? Point to a bad disc. Well, that's the spinous process. So that's it. So normal disc, bad disc, that's flattened out, it's got no disc there, that's no disc, right? And so he's got one normal disc, the rest of them are crappy. Now, where's the canal narrow? Where's that tube get narrow? Right there. Does it get narrowed anywhere else? No, it does not. So does this person need a fusion? No. They're already fused basically because they have a bone spur. They just simply have what's called stenosis, narrowing of the tube. So they probably got some tingling in their legs and pain down their legs and numbness in their feet. So all they need is a little tiny surgery, up there what looks like L3-4 or L2-3, one of those, I can't tell, they're on the bottom of the picture. That's an outpatient surgery, takes about 15 minutes. Go home the same day with a little incision, probably about this big. Go home same day, and you're cured. No fusion, no screws, no nothing. Now, or if you want, I can fuse the whole spine. Don't need it, but I can fuse the whole spine. And I can convince you of that, I guarantee it, if you're in my office, and I was a good liar, but I'm actually an honest person, so I don't lie to people. Next slide, please. So there you go, pain-free. That was actually less than 21 minutes, but easy surgery. They don't need any kind of fusion. Next slide, please. So please use common sense with this. I'm not saying don't trust your doctor, but when it comes to money, all of you very well know there is secondary gain. So if I can convince you to have a fusion when you don't need it, well, then I'll make $10,000 instead of $300, and you'll never know it, right? Understand the problem. You'll be able to tell whether they're full of crap or not, okay? If they don't take time to understand and explain to you how to read an MRI, how to read the films, and you say to them, why do I need a fusion? They can't explain it to you very well, or they dismiss you, leave, run. Get second opinions, but keep in mind, chances are that second opinion is going to look at that first opinion's note and say, yeah, I'll do what that guy said because it makes a lot of money. So be careful. Do your research. And remember, every doctor has some kind of patients that like them in the past. Okay, let's go to questions.
Okay, let me see the chat box. One question on here says, do you ever work with chiropractors?
Yes. Yes. Chiropractors are good. I don't necessarily prescribe it all the time, but I do work with chiropractors. If a patient's seeing a chiropractor and they just have some arthritis, it's wonderful for arthritis because arthritis, as all of you know, is easily treated with only two things. Arthritis is treated with anti-inflammatory medication, arthritis medicine, and range of motion. And chiropractors are experts at range of motion. So chiropractors are wonderful. I do work with them and I love them.
So I have a, oh, one second. Okay, so it goes, when you go for a second/third opinion, do you tell him or her what the first doctor said? Do you give them the x-rays, MRI that you might have gotten through the first doctor?
So give them the films, right? Give them, obviously you have to give them the imaging so they can come up with their own plan. But if I were you, I wouldn't tell them what the first guy said. I wouldn't tell them you had a first opinion. Now, if they come up with something completely different, let's say the first doctor said you need a big fusion surgery, it's going to take 20 hours and you're going to be out of work for 15 years. And the next doctor says you only need an outpatient 15-minute decompression, then you can say, well, why did that first doctor want to do this giant surgery on me that was going to take 3 months? So you want the doctor that you're seeing, the second opinion or the third opinion, to not have that little voice in the back of their head. So you want them to come to you unbiased. And some doctors will be biased if they hear, oh, well, he wants to do a fusion. Yeah, do a fusion. That sounds good. Or it could be that you're getting a second opinion. The first guy is more respected or renowned. And so they'll do whatever that person says. That does happen. Not very often. But if I were you, if you're getting a true second opinion, a second opinion means that they're starting from scratch. So don't give them anything else. Just give them the films, tell them your symptoms, go through the details, and see what they do. If they're a good doctor, they will take the time to explain to you what's wrong with you, why, and how to fix it.
I have a comment here in the section, the chat box as well. It says, Dr. Buono says it like it is. Went to see him for a neuropathy as I was having from my back up into my head, which was causing pain and numbness when I turned my head. He informed me that other neurosurgeons may tell me I need surgery. However, he said that I did not need a procedure. Instead, he suggested a cream that was ordered from a compounding pharmacy in Alabama. Used the cream and it was fabulous, like a miracle treatment. Pain and numbness alleviated for weeks at a time. Use it multiple times until pain and numbness seem to disappear. It comes back every once in a great while now, but it is controlled. So blessed. Thank you, Dr. Buono.
So that's a typical example, you know, you trust the doctor, but when it comes to surgery and things like that, you know, don't forget there's secondary gain. They're going to make money off the surgery. And it doesn't hurt to try something. And realistic goals of the surgery, a lot of people come to me, they have horrible spines, just terrible. They have arthritis all over the place, bad hips, bad knees. And I do a spine surgery on them. I say, look, you know, you're going to get the spine surgery. You're still going to have arthritis in your knees and your hips and your back and everywhere else. But I'll make you 75% better. And they say, man, if you do that, that'd be great. But when they wake up, they'll say, wow, you were right. My leg pain's gone. I still have arthritis in my knees and my hips. My back pain's gone. But you were right. You didn't lie to me. Now, if I lie to them, when they wake up, you're going to be mad if I promise you the world and it doesn't happen.
Another question says, does rheumatoid arthritis complicate some of these spinal issues? If so, does it make it more likely one needs surgery?
No, it doesn't. In fact, usually with rheumatoid patients, you could treat them non-surgically. However, if you're having a surgical fusion in someone who has rheumatoid arthritis, the fusion rates are lower. So people with rheumatoid have a tough time making bone, hence the term rheumatoid arthritis. So because of their autoimmune disease, it can lead to difficulties with wound healing. So usually, more often than not, when somebody with rheumatoid just needs some kind of plication injection in a joint or some type of treatment that doesn't involve surgery. Because a rheumatoid patient is one of those type B or C patients who you do surgery on them, they're still going to have problems afterwards. So let's try to avoid cutting on you, do something smaller, like maybe an injection in your joint, and get you just 50% better instead of trying to get 100% better and hurting you.
There's no more questions in chat box, but you can unmute yourselves and ask your questions if you like.
I have a question for you.
Sure.
Do you work with physical therapists and gyms depending on how people hurt their spines when working out or getting physical therapy?
Oh yeah, we prescribe physical therapy all the time. Physical therapy is one of those ubiquitous things there that I don't care what your problem is. If you get physical therapy, you're going to feel a little bit better. So we work with physical therapists all the time, but keep in mind, physical therapists, just like doctors, they're not all created equal. I've had a lot of referrals to physical therapists where the patient comes back unhappy. Patient goes to the physical therapy, pays their copay, then the physical therapist walks up and says, "Hi, my name is John. Go in that room over there and play with the orange ball for 20 minutes. When you're done, come get me." That's not physical therapy. So physical therapy should be hands-on, and we prescribe it a lot.
I'm just curious, as far as the spine is concerned, if a woman gets breast implants, can that have a negative effect on the spine?
Usually not, no. You know, I've never seen breast implants that were enormous or big enough to cause some kind of a angular momentum on the spine and cause back pain. So no, it's never been an issue in my case.
What if the woman ends up getting bigger breasts and then needs to get the implant taken out?
Well, sometimes people, women with breasts that are too large, that can cause some back pain, especially upper back pain. And so in those cases, then we would refer them to a plastic surgeon to discuss the possibility of reduction surgery.
Mm-hmm.
So we have
and also, I'm just curious if you wear heavy backpacks, or you put a bunch of weight on your back, like heavy books or whatever. Could that cause back problems? Like all those heavy books?
Well, I've operated on a lot of people who are in the military who carry rucksacks. You know, usually they weigh up to 60 to 90 pounds. And that can cause some degeneration of your thoracic and lumbar spine and the joints and in the disc spaces. But usually just a little book backpack is not a big deal.
So we have a question in the chat box. It says, if I come to you with films, is that proof that I'm coming to you for a second opinion?
No. No, everybody comes to me. Well, not everybody. Some people come with no imaging studies at all. They'll just say, I have pain, so-and-so, and what can you do for me? And I have to order the studies. Most people come to me with imaging studies. That's not proof that you had a second opinion. That just means that your primary care doctor or someone ordered some imaging studies on you, and you want them evaluated by a neurosurgeon or a spine surgeon.
And then another question is, what do you think of the McKenzie method by PT for pinched nerve?
So there's a lot of lore out there. McKenzie method is effective, but then again, all of physical therapy is effective for certain types of back problems. But if you look at the bigger picture, for instance, there was this big rush in the last 10 to 15 years where if you build your core, then you're never going to have back problems. Think about that for a second. So let's say you have an 8-pack abs, okay? And you are toned. You're like, I don't know, what's the actor, The Rock, right? You have the perfect abs. And I put 50 pounds of weight on your shoulders to carry. That weight is still distributed 50 pounds additional weight onto your lumbar spine. So whether you have 6-pack abs or not, it really doesn't make a difference. So we've skirted a little bit away from telling people, you know, strengthen your core. It's nice to have a strong core, but it doesn't prevent disc herniations. It doesn't prevent instability or spondylolisthesis or spondylolysis.
Another question is, have you ever operated on someone with a spinal fistula for CSF leak?
Yes. Yes, quite often. So we see a lot of patients, especially since I've been doing this for a while, we get a lot of patients either referred by orthopedic surgeons who don't close their CSF leaks, and they'll call me in either during the surgery or afterwards with a chronic CSF leak or a CSF fistula, and we close it.
So that was the last question in the chat box. Again, if you have any questions, you can unmute yourselves and ask the questions now.
Yes, this is Renee. A part of my question was answered because I wanted to know if you took patients that had no imaging done, because I've had back pain for years and it's getting to the point where I'm gonna have to do something, but I don't have any images. So if I came to you, is the first thing you're gonna do is send me for physical therapy?
No. The first thing we would do is I would talk to you and find out where your pain is, what kind of pain is, find out if is this mechanical back pain, is this neurogenic claudication, and then what you would want, and I would want you to demand that I don't just say, hey, you have arthritis in your back. No. I should show you and prove to you this is what's wrong with you. Look, oftentimes I'll order something called a bone scan. It's a nuclear imaging study which shows you arthritis. So a lot of patients will come to me with chronic pain for years and years and years in back and hips and knees. And I say, you got arthritis, but I can't just say you got arthritis. Go take some Celebrex, right? No, I'll send them a bone scan, and then it shows them a picture of their whole body, like this. And they get to read the scan themselves, because anywhere there's arthritis will show up as a big black spot. And they'll say, oh my gosh, look at the arthritis in my hips and knees. And I'm like, and then they're more apt to say, okay, I see the problem. Now I'll take my arthritis medicine. I'll do a little bit of physical therapy or go get a hip replacement, whatever I need. So a picture's worth 1,000 words. Try not to take someone's word for it, because guess what? I'm not God and I'm not your family.
Okay. So you take new patients, right?
Yes, ma'am.
And you're located right in the campus at Capitol Health?
Yes, ma'am.
Okay. I'll be over to see you.
Okay. I look forward to it.
Okay.
I have a question.
Yes, ma'am.
I have been told I have spinal stenosis, and I've been told that I need decompression surgery. But could you explain that a little bit?
So decompression surgery, we use a lot of terms for it. Spinal stenosis just means the tube, that picture that we showed you, where it showed that big white tube in the middle. So the tube is narrowed, and when that happens, it compresses the nerves, and the nerves don't get happy when that happens. It's kind of like they're getting choked. So decompressive surgery just means, there's a lot of words for it, laminectomy, hemilaminectomy, whatever. It just means you're making more room for those nerves. So removing either ligament away or some old scar or some disc bulges or bone spurs to make the hole bigger so that the nerve is not squished anymore.
The person that I talked to said something about scraping the bone from the top.
Yeah, we could do that. Usually you don't need to, because if you're doing a lumbar decompression, usually you don't need to take down the bone spur. And scraping down the bone or knocking off a bone spur usually just means you're going to make the bone spur come back bigger. So plus you want to do less is more. So I could decompress your canal without taking out and cutting off a big bone spur. That's breaking off a piece of bone. And guess what? That hurts.
I think he was talking about where the stenosis was, scraping off some of the bone on top, not so much removing a bone spur, but making the thing bigger. So
that's called a laminectomy. So he's mingling terms a little bit. Well, we actually cut the lamina off in the spinous process. So it's the top roof of this circle.
Yeah.
So here's the top, and there's a little spinous process sticking up. So I'll cut that off, cut off the lamina. So now instead of being a circle, it's a U, and now the nerves are real happy. And you don't need anything back there because the muscle covers it and it's all happy. So very simple surgery. Usually when someone says you're just doing a decompression, you're safe. It's when people start talking about fusions or weird stuff, or if the decompression will take 3 hours. That's too long. That's no. Decompression should take half an hour at the most.
Okay, because he also said that if you went in there and saw something else, you might have to do a fusion. But he was also talking about 3 hours.
Okay, so there's some danger signs right there, right? So why would you ever sign up for a surgery where the doctor said to you, listen, we have all your imaging studies, right? I examined you, I did all this stuff. And when I get in and do your surgery, I'm not really sure what I'm gonna do. It could be this or that, I don't know. I always go get a second opinion. Chances are you look like you're about, what, 40 years old? So chances are you
84.
do not need, the older you are, the chances are you don't need a fusion, okay? So
I'm seeing another surgeon tomorrow.
good, good. So unless you're unstable, you don't need a fusion.
Okay, let me ask you this. The first surgeon I saw was, like neurological.
Mhm.
The one I'm seeing tomorrow was orthopedic.
Okay.
Was there a difference? And
Well, we train a little bit differently. Ultimately, we all basically know the same things. There are some things that orthopedic surgeons can't do that we can, and we get trained a little earlier, but in the end, we all do the basic same stuff. They just don't do tumors and things like that like the neurosurgeons do.
okay, thank you.
Sure, my pleasure. Please be careful. 3 hours is too long. That's way too long, okay? Any surgery I can do, if it were 3 hours, that means I'm starting the surgery, I'm going to have lunch, then I'm going to the mall, and then I'm coming back to finish. No, that's too long.
Okay, because his comment was if he saw anything else when he was in there, he might have to fuse something.
No, that's not appropriate.
Okay, thank you.
No, I mean, if someone did brain surgery on you and said, listen, when I'm in there, I don't know, if I see anything weird, I'm just going to take it out, and I don't know really what I'm going to do. No. I like to use the word BS. That's BS.
Okay,
No. You either go in with a plan and that's it, okay? Sometimes, very rarely, things can go awry. Maybe you're doing a surgery, you get a little spinal fluid leak or something like that. But you shouldn't be saying, maybe I'll do a fusion. No, that's like saying, I'm going to either clean out the car or I'm going to throw out the car and buy a brand new car. No, it's fusion surgery has different risks. It's a different animal altogether. It has the risk of screw malposition, non-union, bleeding, osteomyelitis, everything else. No.
no.
Absolutely not. No, it's either you have a laminectomy and decompression or you have a fusion. Not, I might do a fusion. No.
Okay, thank you.
Sure.
So we have one more question in the chat box. It says, tingling in foot and leg seems less strong. What is going on due to pinched nerve? ?
Well, it depends on where the tingling is. So if you have a pinched nerve, the vast majority of the time, you think about it, if I take a pair of pliers and I stick it on your nerve in your back, what are you going to say? You're going to say, ow. So usually it has to do with pain, okay? So when you just have tingling, it could be, if it's just in your toes, especially your long toe, your second toe, the one that's next to your big toe. Sometimes you're not wearing arch supports, and you can get what's called Morton's metatarsalgia, which leads to tingling in your toes. And all you have to do is wear arch supports, and it goes away in a couple of months. But it's often misdiagnosed. If it's in both feet and there's numbness all the time, it could be peripheral neuropathy. But usually if it's just tingling and not pain, and it's intermittent, it's probably Morton's metatarsalgia. You can Google that. Morton's, just like the salt, metatarsalgia.
Okay, that was the last question. And I also got a question for me in the chat box. It says, is it possible to get a copy of the recording? The answer is yes. Just private message me your email address. And I'll be able to send that to my supervisor and send it to you guys. And I also want to say, there's a break in the questions. Thank you all for joining us this evening. And thank you, Dr. Buono, for coming and doing this presentation. I definitely learned a lot. So thank you.
Thank you, guys. God bless. Be safe.